This is Dr. Iqbal here. Today, I will be talking about the newer development in hypertension management, and I will be short and precise so that it will benefit more to my patient as well as practicing physician. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular diseases, which affect 45% people in 40 to 69 age group. What do raised blood pressure do? It is among the most important risk factor for CVDs. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow-up. This means that somewhere down the line, people are not aware that they are hypertensive, they are not into regular health checkups, and physicians out there who are attending them are themselves sometimes not aware when to start treatment, to whom to start treatment. And so this is this is affecting a lot of us. In India itself, the prevalence has gone up over 30 years to 38% in men and 32% in women. This is quite high, which was earlier 29 and 28% respectively. Despite that, nearly half of the people, that is about 51% of men and 41% of women with hypertension, were unaware of the condition. As I told you earlier, this is what is happening. Additionally, over 62% of men and more than 53% of women living with hypertension did not get any treatment. Lack of information, lack of knowledge among the practitioners may be one of the reasons. Medication was used to control blood pressure in fewer than 1 in 5 men. It's quite alarming. And 1 in 4 women. Again, it's quite alarming. International Society of Hypertension had released a global hypertension practice in 2020 guideline that include optimal and essential treatment, attempt to address the issue that in resource poor setting, optimal care refer to evidence-based standard of care, and whereas essential standard refer to minimum standard of the care. The HA and ACC guidelines are significant in 2021, offering that for management of stage 1 hypertension among patients with low vascular risk, and in the 10-year CVD risk is less than 10% with stage 1 hypertension. That is, stage 1 hypertension is blood pressure, systolic BP in around 130 to 139 and diastolic around 80 to 89. Management starts with non-pharmacological therapies. Non-pharmacological therapies are lifestyle modification, food habits. These are the non-pharmacological treatment. At least for 3 to 6 months, we consider this before starting the pharmacological therapy. ARDS is potentially fatal condition involving lung damage, and experts after COVID-19 has suggested that the COVID-19 induced ARDS is very, very high. Lowering systolic blood pressure targets down to 1 BP to 110 and to less than 130 millimeter of mercury range substantially reduce CV adverse event in a step randomized trial that was in sprint trial as well as the Chinese population trial which was done. It showed 26% of composite CV risk finding reduction from second major trial, and in the lower target group could unite the guideline, which even among US professional societies ranges from threshold of 130 to 150 millimeter. So with regard to prognostic value of ambulatory blood pressure monitoring and night-term blood pressure, these are very, very important. The office monitoring of pressure was done, but as we all know that the circadian rhythm, the normal blood pressure is high in the early wee hours of the morning. So a night time blood pressure measurement was recommended, that the diagnosis should not only depend on office BP measurement, but also on out of office measurement, such as ABPM or home blood pressure monitoring for 24 hours. And nighttime BP measurements were associated with greater risk of mortality and composite of CV outcome. Thus, they may considered as the most relevant measurement for estimating CV risk. For every rise of 20 to 10 millimeter of mercury increment of blood pressure measured at night, the risk of mortality increased by around 23%, and the risk of cardiovascular event raised by 36%. So most patients with hypertension required lifelong medical therapy to achieve optimal BP control. Therefore, the 2018 European guideline recommended, especially in the context of lower BP targets, to start antihypertensive therapy with initial dual fixed dose combination of ACE inhibitors or ARB plus calcium channel protector or diuretic. So, since early 2018, one product was taken off from the market, was certain because of its carcinogenic ingredients. It was shown with a number of studies showed that they contain some carcinogenic substance, so it was withdrawn. The HYGEA studies represent the large study that tested nighttime antihypertension treatment. In this trial, coronotherapy was associated with significant reduction of endpoint, including death. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CV risk reduction. The largest studies included a total of 19,084 hypertensive patients during an average follow-up of 6 to 3 years. 1,752 participants experienced primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect the data and how BP differed during sleep. Rate of reduction for CV events was significantly improved for nighttime treatment with compared with awakening. This is what we are usually doing. Now, coming back to practicality of treatment, we as a physician have to be more alert, more educative. Rather than just prescribing the pills, we should advise our patients about the signs and symptoms of rising blood pressures and to have them in our clinic at frequent interval, you can say, is to have a BP checkup. The family history is very important. The mother, father, if they are having any hypertensive disease or cardiovascular disease, they should have their BP checkup every 3 to 6 months after the age of 30 years, as we do in diabetic patients too. Since both are metabolic disorder, we should be very cautious. And for my patient, I will say you should be alert. If you have any kind of smaller symptom of shortness of breath, wheeling of head, you should not ignore. Even palpitation, you should not ignore it. You should consult your doctors as soon as possible. And we, as I told, we physicians have a greater role to play. We should educate our patient about these things. We should start early management and target our patient individually to treat the patient if with one molecule, combination molecule, whatever is suitable for that patient to bring down the BP around 110 to 130 systolic blood pressure and 80 to 89 diastolic pressure. Thank you.